So, without further ado, today's Lunch and Learn is titled The Business of Rehab, Finding a Balance Between Patient Care and Productivity. And just some disclosures for today. I am compensated for teaching today's session. I think I have to read this to you verbatim, so let me not try to get creative here and cause poor Holly stress. I am compensated by Summit as an instructor. I'm compensated as the owner of drkatioshea.com, and I'm compensated by Rutgers University as an adjunct faculty. I do have ownership stock option in SableFlex, and I do not have any non-financial relationships to disclose. So we will cover three big things today: the financial and regulatory nuts and bolts in a higher overview, some of the stuff that nobody tells you about in PT and OT school or even in the clinical care part of our world, how to create a system that support both your workflow and your patients, and how to stay engaged and ethical without burning out. My goal is that you leave here not only with more knowledge, but also with a few tangible ideas you can test out, whether it's later today or next week or this weekend in the clinic. Again, my name is Katie O'Shea. I am a geriatric clinical specialist as well as certified dementia practitioner. And just because my hobby is education, I went ahead and became a canine rehabilitation specialist, mostly because my dog hurt himself and it was a lot cheaper than sending him to Canine PT. But I'm more than just my alphabet soup of letters and credentials. I've been a clinician since 2006, and I've worn a lot of hats: clinician, therapist, business owner, management, professor, and of course, proud dog mom. I'm a real person who's done my clinical notes in the car. I've skipped lunch to catch up on documentation. I've stayed up late. I've covered schedules to give my clinicians off. And I'm someone who's tried to juggle too much, sometimes succeeded and sometimes failed. I've seen where we can do things right, where we can get reimbursed and have balance and work within the confines of our healthcare systems. And I've seen it done wrong. And there are some jobs I've stayed at for years, and there's some jobs I've been at 3 months. And I'm sure many of you can share some of those sentiments. And that's why this topic matters to me, because I've lived the tension between patient first and business mindset. And I do truly believe you can honor both. So why business knowledge matters in rehab? Let's be honest. Most of us got into this field because we wanted to help people, not crunch numbers. But healthcare is a business, and we don't talk about that. And if you don't understand how the business side works, it's really hard to advocate for yourself as a clinician, for your patients to receive services, and for us as well as for us as professionals and our professions. When we know what metrics matters, we stop seeing them as the enemy, and we start to use them to drive smarter care, protect our own time, and help to design better workflows. I think we can all agree that if health insurance wasn't a part of our equation, we would probably practice different, but we do have to practice within those confines. So those workflows really will help us. And we also have to talk about, many of us are working in systems with shrinking reimbursements or changing policies. So having the knowledge really is power. And I don't know, might be dating myself, but any of us who grew up with reading Rainbow, right? The more you know, it helps you to have those informed conversations, helps you to ask those educated questions, and helps you to make really sustainable change. So let's talk about KPI, or the key performance indicators. These are the numbers that matter behind the scenes. So these are what your managers are looking at. These are what your non-clinical accountants and leadership C-level suite folks are looking at. These are the numbers that unfortunately matter, right? So when we think about units per hour, cancellation rate, revenue per visit, plan of care completions rates, for example, all of these metrics, they add up and they mean something at the end of the day of whether we are making a profit or losing money. I don't know about you all, but I didn't learn about most of this in PT school. And that doesn't mean we can't learn about it, and it doesn't mean we can't get comfortable with it either. I like to think of it as therapist math, And maybe it's a little trendy, jumping on the girl math trend or the dog math trend with biscuits, right? But it's therapist math. It's not hard math. It's just math with more documentation and a little bit of sarcasm to get you through it. So what's important is that we stop thinking of these numbers, again, as the enemy. And instead we ask, what are these numbers trying to tell us? So it's the same, think about it as your patient who comes into you for an evaluation and they're telling you their shoulder hurts, right? We're not looking at their posture as the enemy. We're looking at, why do they have poor posture? Where is it coming from? What is their body trying to tell us? So the same thing, what are these numbers trying to tell us? Are we just leaking time somewhere, right? Do we have our cancellations killing our schedule? And that's why our overhead is, that's why we're not seeing the revenue we need in the clinic, right? Do we have a strict cancellation policy that we hold patients accountable to? And also, are we billing in a way that reflects the full scope of what we're doing? I can't tell you myself personally, as well as many therapists that have worked for me in the years, so many times we don't bill for our skill. Even the education piece, that is billable, and you have to do it right. So understanding the KPI can help you improve your workflow, advocate for support when needed, and that doesn't always have to be another clinician, and making the case for changing in staff. One more thing about the KPI, the key performance indicators. Not all KPIs are clinical objectives that we look at. Some are about patient satisfaction, documentation, timeliness, therapist retention. And those metrics are just as valuable. Every institution has different KPI or performance indicators they look at. So please don't take this to be as an all-inclusive list. This is really a high-level overview of what some of the KPIs are. So just to go through some of these top ones. Units per hour. This tracks how many billable units you're delivering an hour. A unit, as most of us know, is typically 15 minutes of care. So if you're billing 4 units in a 60-minute session, that's full utilization. If you're consistently billing less, it does reflect gaps in documentations or inefficiencies of care delivery within the clinic and the system you work in. A revenue per visit. This tells you how much money is generated per patient visit. It factors in the mix of the CPT code you're billing. If you're always billing the same low reimbursement codes, your revenue is going to reflect that, even if you're working really hard. So this really challenges us to think, is it really a TE or a TA that I'm billing? Or is this more neuro-re-ed? Is this a higher level CPT code I could be taking advantage of? Then we look at our cancellation rate. Pretty self-explanatory. This is the percentage of scheduled appointments that are canceled or no-shows. The high cancellation can wreck your productivity if you're in the outpatient setting. If you're in the home care setting, right, you're not getting visits paid for those visits where the patient says, I don't want to do anything today once you get in the house, or you get to the house and no one's home. So it reduces our revenue, and it can delay patient outcomes as well. Patients that are only coming in once a week or every other week, they're not having the same benefits and outcomes as those who are really being attentive to their care. So it helps you to look at policies. And most of the time, this isn't on the frontline staff looking at policies. This is your administration staff looking at policies that need to support you as the clinicians with improving those cancellation rates and improving follow-up systems. Right? Patient satisfaction scores. These scores reflect how the patient feels about the care they received. A lot of times they're measured through surveys. Some of those are required through Joint Commission, CARF, things of that nature. Some are just independent facility trying to improve quality, but they cover areas, communication, wait times, ease of scheduling, overall experiences. And a lot of times the patient satisfaction scores do correlate with better outcomes and retention as well. Then we talk about net revenue. So this is the total outcome your clinic receives after deductions like insurance adjustments, refunds, charity care, write-offs. Think of this as the real money you actually collect, not just what you bill. I like to think of it as, I throw my net into the water and what comes out in my net is what's mine to keep. And I don't know why I think about that because I don't fish, but I think if you are into fishing, that probably makes a lot more sense. But think of it that way, right? I throw out whatever I catch, I keep. And that's our net revenue. It's what we're taking home. The gross revenue, this is the total amount billed for all services before any deductions. It's nice to know the helpful starting point, but it doesn't actually take into account the actual cash flow coming into your practice. But understanding these is important because the net revenue and the gross revenue both contribute to your profit margins. And this is what tells you how much of your revenue is left after covering all your expenses. That is salaries, that is electricity, that is building rent or building mortgage payments, supplies. It's the Post-its that someone's swiping from the front desk. It's the pens that the patients are swiping when they sign in, right? It's your TheraBand, it's your TheraPutty, it's your ADL equipment. It's the walkers that can't stay in the hospital because people swipe them when they go home, right? So this is your revenue that's left after all the deductions. So liability, malpractice, overhead non-clinical positions as administrative positions, your HR expenses, 401k, everything after is what is your profit margin. So the healthy profit margin means your business is sustainable, even with things fluctuating like patient volumes or reimbursement changes. And the profit margin is calculated as the net revenue minus the total expenses divided by the net revenue. Algebra, right? So here it comes, the algebra, I don't know, one of those things, but we got equations going on here, therapist math, right? So for example, we'll stick with easy numbers here. Say our net revenue is $1 million. But then say our total expenses to operate the practice with salaries, equipment, all those things is $500,000. So we do the math. So $1 million minus 500,000 divided by $1 million gives us a profit margin of 50%. Now, a profit margin of 50% is delightful. That is not the healthcare trend. That is not where our industry lies. That is not where what is the normal for us. If you're in a clinic that is running a 50% profit margin, I hope you have incredible salaries and bonuses because that's really impressive and hard to do. A very strong profit margin in healthcare ranges from 10 to 20%. So another way to think of this is that means for every dollar your clinic collects, if your profit margin is 50%, your clinic keeps 50 cents of that dollar. So if your profit margin is 10 or 20%, your clinic is only keeping 10 to 20 cents of every dollar they're bringing in. And the profit, right, that money that is exceeding budget or meeting budget, this is what goes back into the company. This is what goes into equipment updates, EMR updates, salary updates, improved staffing, right, improved equipment, things of that nature, CEU benefits. So when we think about it from the profit margin standpoint, if we're only getting 10 to 20 cents of a dollar, it doesn't give us a lot of wiggle room in our profession. So the KPIs are not meant to shame or distress you. They are tools. They're the same as if we're using outcome tools with our patient. It's just on the business side of it. They show patterns and they help you ask smart questions. For example, if your revenue per visit is low, is it because you're underbilling? If your cancellation rate is high, is there something systemic going on? Are you in a SNF and there is a GI outbreak? Okay, there we go, right? Or are there transportation issues? Or is your front desk scheduling you every other hour with a patient and now you have a therapist sitting there for an hour all the time, right? So when you understand the numbers, these numbers that operate a clinic, you get power to protect your time, to advocate for resources, and design smarter workflows. So when someone brings up KPIs, don't just check out and be like, oh, that's my boss's thing to think about. These metrics are in your feedback loop and they are not your enemy. So lean into them and ask questions about them. So the $1 million word, productivity. I think if I did a pulse check right now, we would all kind of groan, right? I don't know about you. I've been hearing the word productivity since 2006. And I hate the word. We all do, because it has such a demeaning context with it, right? If I'm not productive, I didn't do my job today, even if I provided really good care. So what I want you to remember, productivity is not a judgment on your worth. It's a ratio, how much billable time versus how much time you're scheduled to work. Every organization defines this differently, which is one of the hardest things in our professions. Visits per day, points per hour, units per minute. It all differs organization-wise. And spoiler alert, math and ethics do sometimes disagree. And that is really where you need to understand in your own clinical practice and understand the metrics behind the productivity. And, productivity is important because the context of it does matter, right? And if you think of yourself, whether you're a clinician or a business owner, are you going to pay someone to come there and not do their job, right? And just paid to come sit all day? I mean, if you are you hiring because I'll travel, right? But that's not the reality of the work world. So productivity is important because context matters. Are there frequent no-shows? Are you doing all the case management for your patient? Why are we taking that on? What does the patient need to have home care set up, right? Sometimes we have to outsource things and delegate. Is your computer from 1997? Or, where it takes 10 minutes to turn on and warm up, and then gosh forbid you click the wrong thing, the whole thing shuts down? Or are you spending serious time recapping every episode of the latest Netflix thriller? These things affect what's realistic. And productivity, you have to have a balance of it, right? But if we're sitting in the clinic talking all day, complaining, right, or gossiping, that goes into where we could be seeing patients as well. And that is a part that does have to be discussed. So the productivity equation, when we kind of zoom out to look in, right, low productivity, no surprises here, can lead to financial strain, patient gaps, job cuts. But too high productivity, we run more along the lines of burnout, errors, fraud, quality of care, poor patient satisfaction, right? The survey that comes back that says, I saw my therapist for 10 minutes, but they had the rehab aide working with me the whole time instead. So the sweet spot is found in managing your time, documenting efficiently, and scheduling smartly. It's like Goldilocks, not too little, not too much, just enough to keep the business running and you breathing. And this is where I can't help myself, but I do have to make an official bad dad joke in honor of Father's Day. Why did the rehab therapist get promoted? I don't know if you guys can write it in the chat if you have any answers. But why did the rehab therapist get promoted? Because their productivity was off the charts. So sorry. Please don't leave the lunch and learn. But and I don't know about you all, but how many times do you see the clinician who is probably fraudulently overproductive being the one moving up the clinical ladder? And it's a reality of our profession sometimes that from the higher level executives looking down, they want to promote the person who looks like they're doing the best job because they think that person will then be able to bring other people along with them. And it is a sad reality in our profession because that is a lot of times how people get ahead, and it's not always the most ethical way to do things. So looking now at revenue basics, so looking at the money side, clinics generate revenue in a few ways: fee for service, insurance reimbursement, value-based care, cash services. All of these depend on coding, documentation, and being thoughtful of what you bill. And we'll talk about this again later, but just to be mindful, a lot of these do vary depending on insurance contracts, state location, and some government pieces and restrictions. So a fee for service, insurance reimbursement in New Jersey, where I am, is going to look a lot different than insurance reimbursement in Wisconsin, where somebody else might be, versus California, right? So fee for service, this is the most traditional model. Clinics are paid for each individual service provided. So billing separately for an evaluation, a manual therapy session, therapeutic exercises. Some of the pros of fee-for-service: straightforward, service-specific payments. Cons: it can certainly incentivize quantity over quality, and it doesn't always reward efficiency either. Insurance reimbursement. So here the clinic provides care, and that then gets reimbursed by the patient's insurance company. And this is either partially or in full. And this is where the negotiation of rates is very important, or comes into play, I should say. So this covers most patients, especially for those who are private or government plans. And these are negotiated rates. So you know what's coming in. You can plan your budget a little more solidly based off of this, pending any changes in regulations. Some of the disadvantages of insurance: delayed payments, denied claims for errors, if it's written forms, numbers not looking right, getting paid, or data entry errors, and really strict coding rules, making sure your ICD-10s are correct and accurate. There are lots of ICD-10s that cannot be used, and that can really impact your insurance reimbursement. Again, we're talking very high level in all these areas. Value-based care. So in this model, clinics are paid based on outcomes rather than volume. For example, bonuses may be tied to increased functional improvement scores, fewer readmissions to hospitals, and high patient satisfaction scores. Home care is really moving into the value-based care model. So on the pro side, it encourages quality care and long-term results. On the con side, it is hard to track and measure in day-to-day rehab. And this is usually more in the larger healthcare systems, where they're looking at the volume of this. And then cash-based services. So pretty self-explanatory. The patient pays out of pocket. No insurance is involved. This could be wellness visits, dry needling in some states, direct access, or boutique rehab programs, LSVT big, osteoporosis programming, things of that nature, arthritis programming. So the positives of this area of practice: there's no insurance delays, and you as the clinic or the provider have full control over setting your pricing. But the con of the downside of this is it can impact access for patients, some patients, and it can be market dependent. In your lower socioeconomic areas, you're probably not going to be able to get as much volume based on this as some of your more affluent areas. So if we think about when we're billing the same CPT code every session, every time, you might actually be undercutting your own skill set, and also maybe even raising some red flags for overutilization, which on a personal note drives me absolutely wild, because we really don't have a ton of variety in CPT codes to even choose from the start. But always billing, and it does seem insurance goes through phases, right? They're cracking down on TA, therapeutic activity, right now. Before it was therapeutic exercise, neuromuscular re-ed. So it's always a changing cycle that ebbs and flows, right? But I think of CPT codes as a menu. If you always order the grilled cheese, you never know if the tacos are amazing. So mix it up and based on what the patient needs that session. And looking at our care plans, right? If the patient's coming in and we're doing the same thing again and again and again, are we really providing skilled care, right? So if our theracs are not changing, are we providing skilled care? Because as the person gets stronger, we probably can do higher level things with them, right? So what does that look like? So trying to take some of the numbers from our CPT codes and putting them in a real world example. And just a disclaimer, these are fictitious numbers. They are, I tried, numbers for reimbursement are, again, state contract specific dependent. I tried to pick an average number, but this is not going to be accurate for all of you. So just take that into consideration if you're looking at this and say, this isn't what my codes reimburse at. So if we have an eval code, a 97161, we're going to say hypothetically it reimburses $100. 2 units of Therax, 97110 at 80, and this usually reimburses about $30 to $35 a unit, so that number's a little high. And then let's say we have a unit of manual which we're reimbursing at 40, which is anywhere from 35 to 45. So in gross revenue, we have $220 that we should be bringing in based off the use of this coding. But your net, what you actually are capturing, would be around 120, and that would be a 33% profit margin. So you'd be keeping 33 cents of every dollar brought in. Again, that's going to be higher than your typical margin experienced in most healthcare organizations. And the gross revenue is a little bit high in this, especially with some of the states where they do lie in reimbursement. So the gross revenue on this hour treatment, if you're doing from some of the lower state reimbursement, would probably be closer to $180 to $200, right? So then if we take 33% of that, we're looking even less, right? And then, so that difference of what we're going to bring in, that net revenue, we have our profit margin. So if we stick with the number on the screen, the net revenue being about approximately $120 after expenses, things that are taken out. Now we're keeping 33 cents on the dollar brought in. And that's higher than, again, what most healthcare organizations. But what can impact this difference between the net revenue from the gross revenue? Well, the CPT code's used. If this person came in and I build a neuro-READ code or a cognitive code, that can change what my reimbursement looks like. Therapist expense also. A full-time person, part-time person might have a different rate, right? PTA and CODAs versus OTs and PTs, different rates. Also, your reimbursement changes based off of the care setting if you're an assistant versus a therapist. If you have a contract staff member in, because of staffing, that expense is exceptionally higher. And looking also as your therapist on the newer end or on the expensive, more experienced end. You know, did you just buy new equipment for the clinic? Did you just have to buy new Post-it notes because the patient stole them all? Did you have a piece of equipment break and you had to buy a new piece? Did you pay off a piece of equipment? Now you have some extra wiggle room in your budget. So all these variables go into making up that difference between the gross and the revenue and the net revenue. And it also depends on the setting as well, right? So again, this is a high level overview. Hospital reimbursement is going to look different than this and going to be built in more based off of the diagnosis grouping. So the numbers don't lie, but sometimes they do mumble. And you have to listen carefully of all the variables, and they change. They change on a day-to-day basis, right? If all of a sudden I have a week of all my staff are off and I'm paying vacation expense for the staff, but I have to bring in PRN coverage, I'm now paying essentially 2 salaries that week, right? So all of those things do impact that net revenue. So we talk about staying productive and ethical, and it is possible. It takes honest, candid conversations. It takes saying no sometimes. It takes upset feelings sometimes, but it is absolutely possible to do the right thing, both by your patient as well as your own sanity and burnout. So smart scheduling, documentation shortcuts, using support staff wisely. They're not just time savers, they're really sanity savers as well. Even the worst EMR systems have shortcuts. They might not make logical sense, and there are probably some better options out there, but they do. They have shortcuts, and for those different exercises or education that you're providing, that it is a basic template you're starting from, there's no reason to recreate the wheel, right? So using those shortcuts are a huge time saver. If you save 5 minutes an hour, right, that's what, 5 times 8 hours, that's 40 minutes in a day you're saving. So think about it that way. Ask yourself, I challenge you to ask yourself, do you need to be the one to send the fax? Do you have to be the one to call about a script? Probably not. A lot of things you could set up, and delegate. Is it putting things back on the patient or their caregiver? It is sometimes, right? Also documenting point of service. This was an area that I struggled with. I started as a clinician with paper and pen and charts and hard charts, and now everything's electronic. And I was not good initially about doing both, treating and typing, because I grew up learning to be one-on-one with the patient and writing my notes afterwards. And now, I sit with the patient and I'm like, okay, today is your progress report, right? Every day, or every day is not a progress report, I stand corrected. But, today we're looking at your goals. Hey, we're doing this to work on this goal. We're doing this to work on this goal. I'm going to document how you did today. And people, I have found over time, they say, what did I do last time? Oh, I got better. Ooh, I didn't work as hard this time. I'm going to do better next time. And the next time they come in and they're like, yeah, I want to do 70 steps per minute on the bike today, not 58. Don't only talk to anybody so I can focus. And it's that involvement, it's that engagement. And it's shifting a little bit our mindset. It's shifting a little bit our communication strategies. But that is how I personally have found embracing point of service documentation and engaging the client in the plan of care progress, rather than sometimes getting involved in their life drama, right? Do I still like to hear about the showers and the weddings and the vacation and the tea and all that stuff? Of course I do. But I also have a boundary that I'm not giving free time away, and I'm not going to be spending my 4 or 5 hours of my own free time at night doing documentation, right? And so I will redirect people. I'll say, okay, all right, Mary, but I've got to make sure I get this documentation done. Or I say to people, hey, help me make sure I'm giving you the credit we need. How'd you feel with that today? What was your RPE when we did this activity? And that's how I'm doing my point of service documentation. So our goal with, increasing our ethical productivity, it's not to rush. It's not to tell the patient, hush, be quiet, I got to type, right? It's to remove the friction. It's to take away oh, I didn't know I was getting discharged. No one talked to me about my goals. No one talked to me about the why of my plan of care, right? So it's getting them re-involved, reinvested in their plan of care. And it's giving you your time back to get your notes done and to leave on time and to go enjoy your life outside of work. It's about working smarter without compromising care, and that starts with being intentional about where your energy goes. Even if you save 1 minute an hour in an 8-hour day, that's 8 minutes. We just built in an opportunity for you maybe to go to the bathroom today, right? How many of you sometimes don't have the time to go to the bathroom? If we can get you back 1 minute an hour, that adds up, right? Maybe you can actually eat a lunch. We know some clinics are horrific, and some of you are working in those environments. So it's making small changes. It's not expecting those changes to be huge, but it's making them livable and constantly almost setting yourself up with short and long-term goals, right? By 2 weeks, I am going to save 2 minutes with every patient and encourage point of service documentation and address at least one of the goals each session, right? And then maybe your long-term goal is to set for a month that you're going to have 5 minutes within each hour, right? To really kind of get caught up on the things you need to do. Delegation, definitely a good productivity hack, right? Letting go of what's not yours. Do you need to be the one to do the ordering the TheraBand and supplies, or do you like to be in control? Tough question, but you have to ask that. And sometimes when life goes to, we're in a handbasket, I pretend I'm on a game show and have 30 seconds to finish a note and write furiously. And sometimes it works and sometimes the buzzer runs out. But it does, those days where it gets lifey, because it does happen. That's a strategy I use to kind of help me get my documentation done and move it on. Also talking about, stations for activities for patients. If there's an activity that I really like intervention-wise, can I leave it set up in the gym that I can just wipe it down? It's reusable. I don't have to do setup time now, right? And I can do more interactive clinical time and reshift that time where I was setting up an activity to now documenting the activity, documenting the skilled facilitation, verbal cues, avoiding compensations, whatever it was that I provided, and shifting our mindset. So productive thoughts. Let's get real about this. School trains us to be clinicians, but it doesn't leave much room for anything else because there's just not enough time in 3 years, right? And business skills are we get one class, most of us. But here's the thing, we are part of an engine that keeps healthcare running. And that means we have to understand how our work affects revenues, outcomes, and morale. So truly looking at your own patterns, are you always billing the same CPT code? Why? And could you defend that decision in an audit? It's easy when we've been doing this for a long time to just get used to. I do the same 4 exercises for this diagnosis and the same 6 exercises for this diagnosis. But does it have to be that way? Could you defend your decision, your clinical decision in an audit? I think of that. A good clinical question I ask myself, what skilled service did I truly provide today? And how did it help the patient move forward? That's the start of being both ethical and efficient. And then documenting that skill and engaging the patient in that documentation, right? How did I help you move forward? What did we accomplish? And how is this tied to your goal? And you're documenting that, and you're holding the patient accountable. You're holding yourself accountable. If you're an entrepreneur-minded individual, start thinking about how can you fill a market void with your skill? What is it that you offer that isn't out there that would help to make our system a little better? We are highly educated individuals and clinicians. And there's no reason to not show and charge for that skill. It doesn't feel good because we don't talk about it. We spend 3 years talking about how to become clinicians. But there's also the reality that what our profession does also have to pay the bills. So we shouldn't be ashamed of that. We shouldn't feel it as icky, and we should embrace it and step into it. Then you look at finding the balance in the day. This slide's, your gentle nudge, maybe a tough love for some of you, but you have to create boundaries if you want to sustain this work. It is where our healthcare system is right now. And we certainly can have the conversation over we need change in our healthcare system. I think we all agree to that. But just for this moment, we are in an insurance-driven model. And so we have to create boundaries to maintain our sanity. This might mean saying, hey, I love to chat, but I have to finish this note first, and then give yourself the 30-second time show countdown, right? Or using headphones if there's no quiet space. Or if you're highly distractible like me, putting your phone away in a desk drawer so you can't be tempted to text, social media, Amazon, whatever it is, putting it away till you're done talking. I am someone that will talk to a wall. Unfortunately, good and bad. I love to talk to people. I have to know about people. I have absolutely put a sign on my back that says, please don't talk to me. I have no self-control, right? And then it's not, I am able to let go of the piece of, oh man, I feel rude. I'm not looking at someone or engaging conversation. It's, I truly can't. Please don't interrupt me. Please don't talk to me. A conversation, and this might not land well with some of us, but really, truly, honestly asking yourself, are we actually overworked? Are we getting sidetracked by things that don't serve my patients or my peace, right? Am I coming in and spending my first 30 minutes of the day that should be chart review or catching up in documentation, complaining about the front desk, or complaining about an insurance denial, or complaining about Mr. Jones who smells, or Mrs. Jones who never shows up on time? And are it those things that all of a sudden it's 10 or 15 minutes, but now that's a progress report I didn't finish, or it's a home exercise program I didn't put together? Sure, it feels fun to gossip, not even gossip, but vent, right? But how much of that venting is truly time out of your day? And I would encourage you to keep a little running sticky note of that time you spend just engaged in conversation, right? Is it a conversation that enhances you and makes you feel better, or is it conversation that doesn't solve a problem and drains you, and it's the same conversation every day? But doing that time study on yourself, you'll be amazed at where your minutes go. Again, gossip is fun, but it is a productivity and life balance black hole. So, looking at your day, if there's a day where there's a lot of tea going on in the office, and that's the choice that you want to be involved in that tea, beautiful. But then also realizing that might be a day that I'm taking an hour worth of work home with me because it's a choice I made for the day. right? And then if you get tired of that choice, then you make a new choice the next day. And that's just a piece of something I would encourage you all to do, but to do your own time study. And get your teams involved with it too, because sometimes we don't realize it. We don't realize what we're doing when we're not actually taking a look at our time. I remember my very first student, oh my goodness, one of my very first students I had while in home care. It took him 6 minutes to get his blood pressure cuff out, and get it on the patient because he was talking. And the whole time, right, my brain's going, oh my God, take the blood pressure. You got to go. We got 53 minutes here. Let's go. Right. And I was getting annoyed. And then I said something to him, afterwards, and probably sassier than I needed to, but that is what happens. We learn as we grow, right? And I was like, you just need to be quicker. And he's like, I got her blood pressure cuff. I'm like, it took you forever. And I did not have an objective time to say. And he's like, no, it didn't. So the next time we went out to that house, I actually started my clock and ended my clock from the minute he went to get his blood pressure, but time he took to finish it. And it was 6 minutes. And this wasn't a complicated patient that you had to recheck it. Nothing. It was simple blood pressure. And then I was actually able to say, see, here's the time. Wow, 6 minutes. That's almost a whole unit in taking a blood pressure. That can't happen, right? Your skill set should be able to get a blood pressure in under a minute. And especially also if it's in a medical, this wasn't, but if it is a medically urgent situation, you don't have 6 minutes to get a blood pressure, right? So it became a great teaching moment. But we would not have had that moment if it wasn't for actually having a time of, oh, wow, it really did take me 6 minutes. It wasn't just my CI being annoyed with me. I really was chatting and being slow and da-da-da, right? So it's interesting what you'll find when you do your own time study. So just in closing, the big message, don't let productivity be a dirty word. Give it a different name if you need to. Maybe workflow mindfulness, revenue awareness, if that sounds more palatable, if you need that change in your headspace, or stick with it as productivity, right? It doesn't really matter what you call it. It's not a bad word. Understanding the business side gives you power to advocate for your patients, your time, and your value. Track your own data, ask your manager questions and learn what's going on behind the scenes of your individual practice. And then get creative, right? Find those small wins. Start with the minute win and make your long-term goal a 5-minute win. And at the end of the day, realizing that maintaining profit means maintaining your job. It's a world of constant reimbursement changes and loopholes. And it means a world of constantly reevaluating how to keep the lights on in the clinic. What we're doing in 2025 is not what we'll be doing in 2030. Hopefully better, not worse, but we don't know, right? So understanding this is not a set it and forget it type of mentality. This is an ongoing discovery piece. So with that, thank you so much for showing up today. That is a wrap from me. But I'd love to hear from you. Any questions, thoughts, concerns, disagreements, light bulb moments that you might have. You can also connect with me after today. I'm on all the usual platforms. You can email me directly. But that is everything I have for you. I will stay tuned for questions and open it up and thoughts. If you guys have anything to share and add. Okay. Oh, I see a question. All right. Kimberly. Hi, this is a great class. Thank you. You're welcome. I currently work in outpatient clinic and we have to double patients. How can you effectively document? The doubling is a nightmare. I also have to double and I detest it. There's no way about it. I'm not going to pretend to tell you it's fun. But so what I do, I rely on, we're in Raintree, the standard off the model shelf version right now, which no offense, not a fan. But I have templates set up. I have the abbreviation manager set up. So when I have to do those are not the sessions that I am looking to write the world's best clinical note, if I'm being very honest. I'm writing it as I go. And when I'm working with that one person, right, and I'll try to maybe get somebody on the bike or something that's more static and I can just type for a quick second, I am putting in notes in my assessment. I use bullet points of, patient required cues for terminal knee extension on new step today, right? And then I have kind of all my little cues and notes together, and then I piecemeal it into an assessment and into my note. And my rest of my note is just check as I go. And I truly, before I leave one person to go to the next, check off what we did. Um, it doesn't feel good. It's not enjoyable. But that's the strategy I've found that works for me. And then when I have to double the patients, like I usually will then use, those are the patients, those are the notes that I personally do first when I do sit down to finish up things for the day. Because I just feel like they're the worst notes. They feel icky. So I get those notes done with first, and then I'm off my plate. So those are the strategies I use. I hope that helps you. Mika, your question, biggest challenge getting started is startup cost. Any opinions or suggestions? Yeah, startup cost. I mean, that's so clinic dependent. Are you home care? Are you SNF? Are you outpatient? Are you hospital based? What is that? Are you virtual? I personally, look at a whole business plan for that. What do I need to do my job now? What do I have to do my job? Liability insurance wise, equipment wise, cleaning supplies wise, insurance wise, staffing wise. Like, what are my basics, right? And then I make my wish list. So I, in my office, have like a dry erase board that I use in my personal Reiki practice for my 2025 objectives. I have my to-do list, which right now I've only got one of 5 things checked off. And then I have my parking lot of things that I want, my wish list, right? So that's how I personally look at my startup cost. What loan and what cash flow do you have? What debt are you willing to take on and up to? A lot of startup is debt management in that first year, knowing your competitors, what their pricing is, doing some investigative research, knowing what your reimbursement is going to look like, what are your stable income, what's your stable cash flow, what is your variable cash flow. But those are all things to try to map it out in figuring out that startup cost, right? And it's one of those things, like say you want to get into a specialized line or like a specialized niche, are you going to be the only provider in the area? Marketing is definitely a cost that I think you should invest in personally in the startup part, because what's the point of starting up anything if no one knows you're out there, right? But any business always comes with a risk. So looking at what is that financial risk and that tolerance point that you have, and that is different for every single person. But there's lots of forms on Google for like equipment startup list recommendations, and then the HR and the operations side, manuals, law fees, all that stuff, LLC fees. So, spending some time on Google, seeing what you can find for the niche you're looking to get into. But good luck. I will tell you, it's not, the Oprah moment is real, but you don't become Oprah overnight. And no one talks about it in the entrepreneur world of the struggles. The successes are amazing, and the struggles really make you learn and make you think things through. So hang in there on those tough days, because that is something I wish I would have thought about a little bit more when I was getting started. Or I should say knew a little bit more when I was getting started. All right. See, I'm trying to mark these off so I don't go back. Kimberly, I say you said, okay, that makes sense. I do utilize a rehab tech and give her a list before the treatment session to help also. Yeah, the rehab tech, I mean, that's state specific. And that's a slippery slope. It'd be wonderful if we could use them as skilled hands and skilled PT. But they unfortunately cannot document. They certainly can keep a running list, a flow sheet for you, something of that nature to keep you on board, but you have to be the one, providing care and doing the documentation. And Melissa, what's your thought on clinic that has 2 patients on the hour and a patient on the half hour? Okay, so you're saying like 1 to 2, you would be scheduled for 2 patients. So 2 patients would arrive at 1, and then a third patient would arrive at 1:30. Um, I mean, it's staggered, which is helpful. If it's Medicare, it seems like a silly use of, because you're not having 4 and that's not group, so you're just killing yourself on reimbursement. The 30 minutes, that's a tough schedule. I mean, personally, I think that's a tough schedule. Once you know your people, it gets a little bit easier, but then that really goes down to, are you really providing a challenge, a thorough exercise prescription challenge for those patients if you're cranking out that high volume? I think it depends on your work pattern and your work practice, right? Like, I like a little one-on-one time with each of my patients. Be my preference, because then I would get 15 minutes with each person to start, see how they went, adjust any I need, and then get them into the program. But I think that's a tough one, unfortunately. But it's a good idea, right? And so many of these things, you also have to know your clientele, your geography, your patients. That might work for where you're at. It might not work for other parts of the country. I agree. Melissa, he said, I agree, but not sure how to get the boss to understand that. Yeah. And sometimes that comes from the patient satisfaction, that it comes from the patients, encouraging the patients to talk to the management team, right? If they're not happy about things. Because some of those changes, until it comes down to budgetary or outcomes and quality satisfactions, sometimes clinics don't make those changes, unfortunately. But yeah, I would encourage the patients to be honest in their feedbacks and in their surveys, to write a letter, or to have the conversation with somebody when they're in the clinic above you, right? And kind of get that message heard. And a lot of times that message is not heard the first time around. It takes a lot of communicating the same message, which can be very frustrating and kind of banging your head against the wall. But that's what I would do. Sometimes I find the patients are our best allies for sometimes getting change too. The Yelp score is powerful. The Google reviews are very powerful. But great questions. Thank you guys for interacting and engaging. And if you have other questions, you have my contact information. You can call or text that number. I'm most active on Instagram, but you can connect with me on YouTube, Facebook, and LinkedIn as well.